Go, Marc.
Tu me vois? Tu me vois? Hello everyone. I am Marc Kaloustian. I am in Beirut. I am endodontist in Beirut and also a teacher at the St. Joseph University in Lebanon. I am here today. Actually, I'm in the mountains, and you see the view that I have here. So I'm not working, of course, because of the circumstances. And I prepared this lecture especially for you about this new instrument, which is the Endostar. Actually, I had the chance to receive a sample of this instrument, this sequence, a few months ago, only 6 or 7 months. And you know, as an endodontist, I am an endodontist since 2003. When I have some instrumentation that I work with, and I know this instrumentation works. And when you receive a new instrument, it's always, I think most of you has the same feeling, it's always a little bit difficult to start to work with it because it is something new for us. But every instrument, new instrument, can be an improvement in our daily practice. And when I started using the Endostar instrumentation, I started first on blocks, then on extracted teeth. That's what I always do. And then I started working on patients. Now, what I want to say here is what is important for me today is to give my personal experience with this instrument. And I found it is a great one, but I want to give my clinical experience with this instrument, not to stick with some protocol or another. So you will see how I work with it. And I think every clinician, when he use an instrument, he will use it and see how it works well under his hands. But before talking about the instrumentation, we have to keep in mind something very important. The problem when we work on teeth, on patients, when we do root canal, is that we work on the tunnel. The slide is not changing. I changed the slides. Can you see it now? The problem is when we work on a root canal, we have the term canal. We feel that it's like a tunnel. So we go inside and we start shaping the canals. But what we have to keep in mind when we do this, we have to keep in mind that we are not working only in a canal. We are working on a system. And we know this for a long time ago. But every time we work, we forget this. That's why I showed this X-ray here. On this X-ray, you can see you can see anastomosis on this case that I did. I'm not saying that every case I do, I have this kind of anastomosis, but I have to give to myself all the chances to close all the anastomosis when it is possible. And this will be done during the shaping, during the cleaning, and during the 3D filling of my obturation. And see how the complex is the system. These are images actually from deciduous teeth, not permanent teeth. I'm showing them. These images were done from micro CT, and these images were done from a study that my wife did. And you can see on deciduous teeth how there is anastomosis, how complicated is the anatomy. And it's exactly the same when we are working on permanent teeth also. So what we need to do is a 3D cleaning, a 3D shaping, and a 3D filling of the entire system. In the middle, you can see cases. And you can see on these cases how we were able to clean, shape, and fill the canal. And you can see also on the left and the right, micro CTs done on teeth, on extracted teeth that we did to show how the filling should be tridimensional, how it should be dense when we do our filling. And this will depend from our shaping during the treatment. Let's talk a little bit about the shaping rules. The shaping rules are extremely important. Actually, we know these rules from 40 or 50 years ago. I was not even born when these rules started. And we know them from a guy who is called Herbert Schilder, from a very simple article that he wrote in 1974. And these are the titles of his chapters. I'm not going to go on every point on this one because you all know this. But what I want to emphasize on is that these shaping rules shows something very important. It shows that what we need to do is to work tridimensionally. And the second point is we need to respect the anatomy. That's why he is talking about the position of the foramen and the small opening of this foramen. And when he is talking about the small opening of the foramen, he is one of the first who is talking about the conservative endodontics. Conservative endodontics didn't start yesterday. It started 40, 50 years ago. When we keep the anatomy of the foramen as small as practical, we are conservative. Of course, now we have more tools to be more conservative also, but the idea was here since then. And the idea here, you can see it on the right. We have a tooth. You can see these black circles. The idea is very simple. Each one of this circle at the foramen, we should have the smallest circle and then bigger, 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 bigger. And we need to do this on the X-rays. We need to do this on every case that we are working on. This case can be a simple case, like here, for example, in this molar. In this molar, it's the upper 7. We have 4 canals, separate canals, but we don't have that much curvature. We need to give a taper according to the diameter of the apical part. And remember always these black circles. Smallest one at the foramen, the biggest one at the orifice of the canal. Here we have more curvature, of course. But this curvature, it's a continuous curvature. So it is not that difficult. If we have a flexible file, like the endostar, for example, it is easy for us to go till the apical foramen without any problem in this kind of anatomy. Or it can be more difficult. What is difficult here is that after the curvature, we have 6, 7, 8 millimeters of canal. So we have to shape this part without doing something very important, not transporting the canal. And this is the idea of keeping the foramen as small as possible. Because if we enlarge the foramen, we will transport the canal in cases like this one when we have an acute curvature. And we, of course, transporting canal is like a zipping, so it's like a perforation for us, and it will become a failure. So now let's talk a little bit about the philosophy of this instrumentation and the philosophy of our shaping. Our philosophy is a crown down, step down concept. And we have to take the instrumentation, this new instrumentation that I start with 6 months ago, and adapt this instrumentation to this philosophy of crown down and step down system. So we have here many instruments. We have, first of all, a pre-flaring instrument, which is the 3008, as you can see here, the first one. It's a small one. I like this instrument because it has lots of taper, so it can enlarge the canal at the orifice, at the beginning, in the coronal part of the canal. Then we have another one, which is the 2004. I consider personally the 2004 as a glide pass instrument. Meaning it will give me the pathway to the canal before our shaping, our final shaping. And then we have a very, very important instrument under my hands. I love this instrument, and I will show you why during this presentation, which is the 2006. The 2006. The 2006 will do my main shaping during my treatment. I can do most of my shaping in a small normal canal with this 2006. But sometimes we have larger canals because we are dealing with nature, we are dealing with anatomy. And in cases like this, we will need to do additional shaping with 2504, 2506 most of the time. And sometimes also when we have very large canals, we can go till 35, 30, 35, 40 and 45. You will notice that when we are at 30, 35, 40 and 45, the taper will be smaller, 0.5, 0.4, because we don't want to enlarge too much the coronal part and we want to stay conservative. So if we take a simple case like this one, it's an upper molar, classical with two canals in the mesial canal. You can see the X-ray here of the files with the two files inside the mesial canal. In a case like this one, I was able to go to the foramen very quickly with a number 10 file. Okay, I was discussing this topic a week ago with my friend Dr. Marc Habib, and we discussed about this, that sometimes we can go directly with a number 10 file till the foramen. So this is not a problem. If we go very easily, we can not do the glide path. It's not necessary. So I won't use here the 2004. I will go with my pre-flaring, which is the 3008 in the middle, and then directly I can use the 2006. Of course, I don't use it directly till the foramen. I have to do it slowly. I go slowly till I arrive to the foramen and till I do the final shaping that you can see on the right side of the slide. This instrument, the 2006, I like it as a final shaping because it will give me the shape and I can be also conservative. So I can have my goals without destroying the tooth. This is very important. This is the idea of conservative endodontics, which means conservative prosthodontics also, because my tooth should be functional after I do my treatment. That's why on this upper premolar, for example, you can see that I didn't enlarge too much the canals because I didn't enlarge also too much the coronal part of the tooth, the access cavity. And at the end, I can have a shaping that is not very large, very small apical diameter because the anatomy of the tooth give me the opportunity to have the small apical diameter, and a good shaping at the final with this one instrument, which is the 2006. So if we talk a little bit about this instrument, we can say, I know there is many lecturers who talked about it before me, about the anatomy of the instrument, the geometry of the instrument. So I won't go in details in this. It's not my specialty. I want to show my clinical experience, my clinical input with this instrument. But let's say something very important. It's the section of the instrument. This section, as modified section, will give me the opportunity to be very efficient when I work with this instrument inside the canal. It's a cutting instrument, and we love cutting instruments. And also, of course, we have a safety tip. The tip of the instrument is safe, so we cannot do a ledge when we are working with the instrument inside this canal. And if you see on the right, you will see that the instrument we can bend it. We can bend the instrument. So by bending the instrument, it will be possible for me to go inside curvature, and we'll see, and to go when we have a difficult access during the treatment. Look at this. I can bend the instrument because this instrument, it's a Martensite instrument. So I can bend it before I go inside the canal. And when I am inside the canal, it will transform in austenite. So I can use the advantages of the austenite, which is the efficiency of the cutting of the instrument, and the advantages of the Martensite, who is the flexibility and the resistance, of course, to breakage. Look, here I pre-bend the instrument so I can have easy access in this canal. As you can see in the video, I don't know if the video is working. You can have an easy access inside the canal. You can have the easy access because we can go inside it very easy. It's in upper 7. We can go inside without a problem. The access is very important. Sometimes we are working on mesial canals and we don't want to open too much the access cavity. So we keep it as small as possible and we pre-band the instrument to go inside the canal to have the access to this canal. I don't know if you are seeing now the video. There is a small delay. I was showing in this video that I can go inside the canal by pre-banding the instrument. I can reach the orifice easily in difficult access in molars. Now I want to show you few cases of the use of this instrument, when I can use this instrument. I want to show you a case when we have a double curvature. It's a vital case here, as you can see, and we have on this case a double curvature on the mesial canal. This mesial canal had 2 canals, but there were joining canals, so it's a type 2 of Vertucci configuration. When we need to go inside this kind of canal, what we need to do is to reduce the Schilder triangle, because we don't want to open too much the access cavity here. We don't want to open too much the access cavity. So we need to have a direct access without opening too much the access cavity. That's why we need to remove this triangle here, as you can see it on the X-ray. And here I can use the pre-fairing instrument, which is the 3008. This 3008 will go just before the beginning of the curvature. It is very important not to go inside the curvature with it, because the taper of the instrument is very large. So it is very advantageous at the orifice, but it's not we don't have an advantage to go inside in the middle part of the canal. And then what we do is we go at the first curvature with the glide path instrument, what I call the glide path instrument, which is the 2004. With the 2004, I go only to the first part of the curvature, not in the apical part, as you can see here. The 2006 here, a larger taper, I can go with the 2006 at the same place of the glide path, not till the foramen. And at this stage only, I can take the length of the canal. Why? Because by doing my pre-flaring, as I did now, by using the pre-fairing instrument, and even by doing the glide path and this till the first curvature, I straighten the canal in the coronal part. So by straightening the canal, my length can change. So at this point, I will take the length of the canal. And then, very easy, I will check patency and go with 2004 till the apical part, followed by 2006 till the apical part. And I will stay up with 2006 in this canal. Now this is the final result. You can see that I respected the anatomy in the mesial canal of this tooth. Now if we look at the distal canal, we also have a small curvature in the apical part. So what is our protocol here? Our final shaping in the distal canal will be 2006 first, and then I noticed that my foramen is larger than a 20, of course, here. So I used a larger file, which is a 25. But I don't use the 2506 because it has too much taper. I use the 2504 because I want to have a small taper with according to diameter, because I have a small also curvature in the apical part of the tooth. Now for the palatal, of course it's much easier. We can go with the 2506 and 3004. And if we feel that the foramen is larger than 30, no problem. Go with a 3504 or even a 4004 or even a 4504. It depends on the initial anatomy of our tooth. So this is the mesial canal with only the 2006 at the apical part. Now, we have sometimes more difficult situations. If we have a difficult situation like this one, sometimes we cannot see it on the X-ray, what we call the ledge. if we have a ledge or the beginning of a curvature, maybe the ledge we did it during our treatment or during a retreatment, it is very important for us to know that we need to go there with hand files. At least this is what I do personally. We go with a hand file pre-curved, and the hand file that we will use will not be the number 15. We should remove number 15 from our instrumentation because this file is too stiff and it can worsen the ledge that we have. We can go with a number 10 pre-curved, or we can go with a number 8, and sometimes even I go with a number 06 in this kind of canal. So this is a number 10 file pre-curved. I took this photo from my friend Dr. Zahir Taki, because he showed in a webinar very well how we should pre-curve the number 10 file. And this is very important. And when I saw him showing this, I said we are thinking the same thing. We should pre-curve it in this way, only the last 2 millimeters. And if you look at this case, this retreatment case, there is a post. It's easy to remove the post here. We can go inside the canal with a hand file, small hand file here. It's number 10. And at one point, you can see I felt a blockage. We don't see it on the X-ray. It's not necessary to see it on the X-ray. So we pre-curve the file. If we consider that this blockage is a calcification, we will have big problems. And that's why I heard a lot of time from dentists. They said the apical part is calcified. If you think it is calcified, it means that you will go and press and force inside the canal. It is never calcified in the apical part. Very rarely calcified in the apical part. Calcification starts coronally. So that's why we know it is not calcified. We know the problem we have. It's a ledge, and we know that we need a pre-curved file to bypass this ledge. And most of the time, 90% of the time, very easily, we can, with some patients, bypass the ledge without forcing with the file inside the canal. Once we bypass the ledge, and I love taking X-rays with number 10 files or in the canal in cases like this one, because I want to be sure that I am always in the password of the canal. And when we do this, then we can do our instrumentations with the night eye file. In a case like this one, I will use the 2004 file, of course, as a glide path. I can pre-curve it like I pre-curved the number 10 file, why not? And I will finish with the 2006. As you can see, we have a curvature. It's not a very acute curvature, but sometimes this kind of curvature are even more difficult than the acute one, because we don't see them, so we don't pay attention and we do a ledge. And we have also, I'm showing here another case of a retreatment case also, where we have a ledge in the coronal part, in this mesial root of this tooth. As you can see, it's a retreatment, so we have some product inside the canal. And this is the picture when, actually this is the case that was done from a colleague from mine, and he did the bridge. And after a year, the patient started feeling some pain on the tooth. So he sent it to me. He said, I had lots of problems with this case, and I searched for canals. In the middle, I didn't find the canal, etc. So I'm sending you the case. I want to remove the bridge, but first try to do the endo through the bridge. So this is when I opened the access cavity. You can see we have the mesiobuccal, the distobuccal, the palatal, and in the middle we have something pink also, that the previous dentist put inside the canal. So when I opened, I removed all this. I used the ultrasound to remove all this stuff from inside the canal. I noticed that MB, DB, and P was okay. In the middle, actually, it wasn't a canal. We looked at the microscope. It wasn't a canal. It was the dentist who were trying to work inside the pulp chamber, started this kind of perforation, but it was not perforated. So we were okay from this side. And then started doing my retreatment procedure. There is a retreatment files for the endostar, but I like usually to use the same sequence for my retreatment and for my treatment, because I want to be ergonomic. So I tried, in this case, to use the pre-flaring file to do the retreatment, to remove the material. And I did it without solvent because I don't like that much to use the solvent, as many studies show that solvent can cause many problems, like creating a chloroperca inside the canal when we are working. So we did it in the mesial canal, only the obturated part, the palatal canal and the distal canal. And after removing the material with a pre-banded number 10 file, I don't know if you are seeing the video here, I am using the pre-bent number 10 file to go inside the canal. I pre-curve it and I try to reach the patency. And it is very important here, especially in the mesial root of the tooth. Now I can add more pre-flaring after doing number test, because I want to have a nice access to the apical part in these canals. So I am doing this number 7 pre-flaring in all the canals, the mesial one, then the distal one, the mesial one, then the palatal one. And you can see here how much debris we have on the file when we are using this instrument inside the canal. This means I'm very happy when I see this, because this means that my instrument is very efficient. And here I'm doing the glide pass because it is small canals. On the X-ray I cannot see the canal. This doesn't mean that the canal doesn't exist. So I'm doing the glide pass with number 20 or 4. This article shows very well, and there is many other articles, that by doing glide pass inside the canal we will have less transportation than by doing manual glide pass inside the canal. So this mechanical glide pass with this instrument is very nice, and you can see that by using this instrument we are even able to remove more gutta percha from inside the canal, even after doing here for example, you can see from the palatal canal, when working in the palatal canal, we were able to remove some gutta percha, as you can see here on the file. So during the retreatment, during the whole retreatment, we will have the possibility to remove the and now we can use the 2006, which will be the final file in this case, because it is small canals and we don't want to enlarge it too much. What is interesting with this file is that I can use it in the brushing motion. So the brushing motion is excellent. Why? Because I have a small taper, only 06, I don't want to go larger, but in the coronal part I can do brushing. And by doing brushing in the coronal part, you see how much debris I am removing. I am enlarging the coronal part, but keeping the apical part very small. Of course, it is even easier in the palatal, as always, because the palatal is a large canal, as you can see. And this shaping that I give will give me the opportunity to reach my goal. What is my goal? My goal is to do the cleaning. And here I am doing the cleaning, and see with this irreflex tip, flexible and tapered like my instrument, how can I remove debris. And here too you can see that I am removing also some gutta percha. And here I am going to talk a little bit about this. Many articles showed that during the retreatment it is very difficult to remove this gutta percha from inside the canal just by our mechanical and our passive cleaning irrigation. That's why it is important to do some activation inside the canal. Here for activation I am using the sonic activation. It is the MM100 1500. You can see this will do some cavitation inside liquid and acoustic streaming that will give me the opportunity to remove even more debris. On the left, this is the article we did about this instrumentation, and we showed that it is when we use a sonic instrumentation, and other article shows when you use ultrasonic passive activation, we can remove more debris from inside the canal. So this is a prototype, and you can see how it works inside the canal. Here too, debris are coming out by doing this acoustic streaming inside the canals, all the canals. First of all the distal, then the mesial canal. in this mesial root, and finally we will do it also in the palatal canal of the case. Now, for the obturation, to finish this presentation, I personally like to do a vertical compaction. This is a technique that I like, and I'm showing here a very old article, but I think it's a great article. I know that there is many other techniques, and these techniques are very good. They are excellent. Many studies showed that the bioceramic obturation is very promising. I have my friend Dr. Rulal Hashim, who did a very nice study about bioceramic showing it's very promising. But I think that we still have the opportunity to use, and I do it every day in my clinical practice, we still have the opportunity to use this warm vertical compaction. And what is interesting in the warm vertical compaction is the thickness of the sealer that we have when we are using it. And this was shown in this article with microscopy, scanning electron microscopy done by Schilder and his crew. It was shown that the sealer is only 40 to 100 microns. So if we have resorption with time of this sealer, we still have lots of gutta percha, and we still have the success over the years during the treatment. That's why I'm showing in the mesial canal how I am using. This is the classical vertical compaction. And you can see when using the microscope, we can see very easy inside the canal. So we can very well go inside and do our compaction very easily. When I do this technique, I like to use the touch and heat because of the tip of this touch and heat. This tip is very small. It can go inside the curvature. It's a 0.5 tip. When I do continuous wave, sometimes I do continuous wave, I can use other instrumentation like the fast pack or so on. They are very good for the continuous wave. You can use also the warm vertical with it, but I am used to use this very small tip because in long canals like this one, I can go inside and clean and do my vertical compaction. As you can see, this is the final X-ray showing the respect of the anatomy of the tooth with using this instrumentation, the 2006 here. And finally, what I want to say is that we have some guidelines always, and we have to follow these guidelines, and we have some protocols that the manufacturer will give us or other dentists will give us, like I gave you a protocol today. But what a message I want to give is we have to take these guidelines, take these protocols, but sometimes we need to play it a little bit free jazz, like John Coltrane. I want to finish this presentation by presenting the next one that will be given by Dr. Ashraf Samir Rifai, and it will be on Tuesday the 14th. He is from Egypt, and I am looking forward to seeing him on Tuesday. Thank you very much, and I don't know how I will answer to the questions, but all the questions are welcomed. Maybe I can answer on Facebook. I didn't open it yet, or if you can send me an email, I'll be happy to answer to all the questions of the audience. Thank you very much. I hope you like it. Show me. Yes, I have a question about the glide path. Je commence avant. I have a question about reciprocation or rotation. Yes, yes. I forgot to tell you. I didn't forget actually, but I had only 20 minutes for this topic, so I took only one part of the topic. Of course, this instrument can be used in reciprocation or in rotation. I personally actually used it in rotation in all my clinical cases, but we are doing a study with one of my students, he's not doctor, he's still a student, and we are doing a study, and we tried it in reciprocation and rotation, and these instruments work very well with both of these motions. So we can do it in reciprocation or in rotation without any problem. I didn't use it clinically, but on blocks it works very, very well, and I think even it was a little bit quicker when we were using it in reciprocation, but this we need to see the studies later. Question number 2, does the file have a suck-in property? I didn't understand what does it mean, a suck-in property. Maybe if you can ask me again the question, I will answer if you give me a clarification. Germain, it's not a 25, or I didn't do any case. I never do a case with a 2504. Maybe it wasn't very clear. Sometimes it was a 26 followed by 2504. So you are taking the advantages of a taper of the 26. Now this is what I want to say about the 2006. This instrument is very efficient when you are working. It is very efficient on brushing. So I am using it always in brushing motion. So I can give more than an 06 taper with the 20 actually. That's why I can use it in the palatal canal and still have large tapers in this kind of canals. So the idea was that I gave the taper with the 2006. Now I need only in the apical part to go to 25. That's why I am using the 2005. So yes, it is sufficient to do this, to give the main taper with 2006 and to do at the end only 2504 or 3004 or etc. But now sometimes if we don't have, the case I showed, we had a curvature in the apical part of the distal canal. That's why I used the 04. If we don't have the curvature like it was in the palatal canal, in that case I can use the 2506 without any problem and go till 3004, 3504, etc. The question of Lin Khazaa. It is a very nice question. She's asking about the glide path. She said, isn't it too much, 2004? I think it's a little bit too much. It works, but it is a little bit too much. And I think the manufacturer is working on another glide path instrument right now. That's what I understand for the manufacturer. But it works. Usually the 2004, it is a very thin instrument, it is very flexible, so it can go easily inside the curvatures. I did it, and in many cases, and it works. But maybe a 16, a 15, a 17 instrument will be also more effective for doing the glide path. The dynamic of movement, I am using here the rotation. I don't know if this is the question. I am using the rotation. I'm doing a push-pull, in and out actually, in and out action with brushing. This is the way I work with it. You cannot do the brushing. But if you don't do the brushing, sometimes you will have very thin canals. The brushing is done, of course, only in the apical part, in the coronal part, sorry. When we arrive in the apical part, we did our job, the pre-flaring, so the crown down in the coronal part. In the apical part, we don't need to do the brushing. So with the same instrument, and I used to do this movement with many other instrumentation. The Pro Taper Gold, the Reciproc, all this instrument. I used many instruments in my life. I always do this. I never do brushing in the apical part because I don't want to zip the canal. Even though it is a tooth with an instrument heat treated, very flexible, in the apical part, 3 millimeter in the apical part, I pay attention not to do at all brushing. Question number 6. I am using this file at 300 RPM. with all the instruments. I don't. Actually, if you can see, the manufacturer will give you the RPMs. I think it's 300. Usually, I don't change the RPM with the instrument. I don't want. I never had this kind of problem with any instrument, so I always use it with this one at 300 RPM. Yeah, screwing effect. So the question about the screwing effect, the sucking effect. Actually, we don't have it at all. I think it is because of the geometry of this instrument. And what I noticed is all heat-treated instruments, they don't have this screwing effect. And this instrument has also variable pitch. So maybe it will work if you do it on a block, as you can do. As for all the instruments that you are using, you will have this screwing effect because of the nature of the material of the block. But if you are using inside the mouth, you won't do a screwing effect. So I want to also give you a small tip about the screwing effect. If you work without brushing, even with the best instrument, if your canal is very thin, it is calcified, you will have screwing effect. It is turned down. It is. Maybe. Let's see. Now, if you are using a file in a small canal, you will have a screwing effect if you don't do brushing. That's why also you need to do brushing. The brushing, it's a safety for you not to do, because always when you do brushing, you try to go coronally. So you go coronally and you go down. Coronally and you go down. It is a very passive instrumentation, and it is efficient because it will straighten the canal, but not in the dangerous part of the canal, in the safe part of the canal. So not on the furcation. Always it is parietal movement. You choose a wall, a safety wall, and then you do the brushing at that point. Let me see other questions. Precurve, okay, do you directly go with precurve 40 or any steps in between, please? For years now, I'm not using more than number 10 file before doing my night eye instrumentation. Yes. So I am using I use always manual 0810, and the 2004, the glide pass instrument, I use it directly after the number 10. Now, the idea is, if the canal is very small, you need to do something very important. You need to do first pre-flaring, then glide pass, but not till the end of the canal, then again pre-flaring 3008, again glide pass a little bit. Okay, why I don't want to use number 15 or number 20? It is the same question of, I think, Dr. Lin Khazaa. Maybe 2004 is too much for the glide pass. And probably there will be a new instrument, glide pass. But it works if we do it pre-flaring, glide pass, pre-flaring, glide pass. Why I don't want to do 10, 15, 20 hand files? Because between the 10K file and the 15K file, we have the augmentation of diameter of 50%. And this was said also a very long time ago by Herbert Schilder. That's why he created the Profile 29 instruments. Profile 29 instruments where you had 10, 12.9, and then after each instrument you have 29% of diameter augmentation. The problem is from 10 to 15 we have 50%. So what you notice is when you go with the 10 and then you go with the 15 is very far from the 10 and the 15 is very stiff. And it is the same from the 15 till the 20. That's why it is very advantageous for us to, after number 10 file, with this kind of file that are very resistant to fracture. Of course, you should not use the file 100 times, but it is resistant to fracture. You can go directly with the rotary without any problem. And it is even more safe, I think, if you do it by reciprocation. Let me see what we have also. can you tell us steps on the tools? Uh, can you give me more clarification about the question? I didn't understand it quite well. Il y a d'autres questions plutôt? Dr. Farida, I don't know if you can. Maybe you can send me an email later with to and give me more clarification about this question, and I will be happy to answer to it. So if there is no more question, I want to thank you all for today, and I was very happy to give this webinar and have. We have one more question. Do you have single file use or what is your? Yes, this is very interesting question. I personally my preference is to use the files single time. One time and then through them, and we know why all. We know it because it is very difficult to clean this instrumentation, all the instrumentation. And all the studies showed that we still have debris, even where we are cleaning them very well and doing all of course, the protocol of disinfection. So that's why I like to limit my instrumentation, and this is also the idea of my protocol. I don't use 10 instruments when I do my treatment. I like to limit my instrumentation to 1 or 2 files, and then we can use a new instrument. Now, if you are doing on the same patient, sometimes it happens that we do on the same patient, we have a long appointment, 2 hours, 2 hours and a half, and sometimes the patient needs to do 2 molars. You can do 2 molars with the same instrument. The problem is not the fracture problem, it's more about the cross-contamination problem that we have. And I think this instrument, which is not maybe not very as expensive as other instruments, it is good to use them one time. But if you look at the resistance to fracture, you can do, I think, more than at least 10 canals without any problem with this instrument. Yes, about the glide pass, we have lots of questions. I love to do glide pass with many other instruments also. I am using the glide pass with a number, I did it long time ago with pass files. I use the Air Pilot, I use the glide pass, the Pro Glider. Many systems, all the systems are good for the glide pass. There is no problem with this small glide pass. But even if you take, for example, the Pro Glider, which is a glide pass instrument, the Pro Glider has a good taper. It has a variable taper, and it has a large taper in the coronal part. And it is a very effective instrument when working with. And the tip of the Pro Glider is number 16. Now, if we are working on a central or a very large canal, personally, I don't use glide pass. I'm not fanatic. So if I see that I don't need glide pass, if I see that I can go with a number 20 inside the canal very easily without any problem, there is no curvature, there is nothing, I don't need to use any glide pass in cases like this one. Okay, so this is the end of the session. If you have more questions, no problem. You can send them to me by messenger, by email, as you want. And have a good weekend and cheers. Bye. C'est bon?